So today we're going to be talking about abdominal pain, specifically functional abdominal disorders, or what we previously called those, and what's now known as diseases of gut-brain interaction. And the title of the talk is Butterflies, Brains, and Barriers. No financial disclosures. This is probably not really accurate anymore. I actually have a couple financial disclosures. So I work with Fodzyme, a company that makes FODMAP digestive enzyme, and a few other entities. I'm currently a PI for Ardelyx, which does a drug that is aimed at IBS-C. So those are two conflicts. So we're going to understand the prevalence, demographics, and basic mechanisms of chronic abdominal pain, grasp the connection between stress, inflammation, sort of nerve signaling, and intestinal barrier function pain, and then use this to understand why therapies work and what they are good for. Minimize this. See if this works better. Okay. So the first thing I bring up when I talk about this is what's called what I call the fire alarm analogy. So the fire alarm analogy is basically the idea that imagine you're at home and you're in the middle of the night, you're sleeping, and the fire alarm goes off. And you're like, okay, that's not good. So you wake up, you go outside, you wait for the fire department. They come and they say, everything's cool. You're fine. The next night, the fire alarm goes off again. And you're like, oh, that's a pain. I better be something for real this time. You go down, fire department comes, everything's fine. They send you home. You're like, well, that was a pain in the ass. Third night, fire alarm goes off. Do you think it's the fire alarm or do you think there's a fire? So the problem here is that you have the alarm. And this is often what's basically happening in diseases of gut-brain interaction, which is that the problem is in the wiring. The alarm is misfiring or misreading. Now, the other part of this that I think is a useful analogy is a lot of physicians get weird about diseases of gut-brain interaction because they're hard to pin down with some sort of specific test or something else like that. And sometimes people think that patients are histrionic or it's in their head. But imagine how deeply unpleasant it would be to live with a fire alarm going off in the middle of the night every night of your life, and how many externalities that would create in secondary problems. So it's really useful to think about how bad this is. So what is the problem here? Well, the problem is part that visceral pain is extremely bad at reporting specifics. So the somatic nervous system, the visceral nervous system are different. The somatic nervous system is your hands. It lets you tell stuff is smooth, tough. It lets you tell where things are. It's how you feel everything around your skeletal apparatus and your skin. It's very accurate. You know if someone touches you on the forehead, that it's your forehead. You know if someone touches you in the hand, it's your hand. Now you do have some parts where it falls down. Everybody's got that infamous 2-point discrimination test from medical school that I'm sure we all got taught and remember. But for the most part, it's much more localized and specific. The visceral nervous system does not do that. The visceral nervous system is very, very generic and nonspecific, and very much does not like to report exactly what's going on. It mostly should be efferent flow that's going to that's going to tell the body what to do. But it does get a decent amount of sensory information back, primarily from the intestine. The information it gets back from the intestine, it cannot tell the difference between, which is part of why you see such shifting, moving pain when you have somebody with diseases of gut-brain interaction, because there's no localization. What actually causes a lot of the pain is distension. So it's making the intestine stretch. But the thing is, people relate that and say, oh, well, it's gas or something else like that. Like, that's not a big deal. But like making the intestine stretch is part of the pathology in almost all things that we see. That's what causes pain in IBD for the most part. That's what causes pain when you're obstructed. That's what causes all sorts of these things. Ileus, that's what makes it hurt. Until you get inflammation going through the wall of the intestinal epithelium and the whole intestine, you don't really get activation of the somatic nervous system. So it's all nonspecific and generic, and you have no idea what's going on. When you have recurrent pain, the other part of the problem is that this creates essentially a sensitizing effect. The analogy I like here is imagine that you have a nice park and a walkway through the park, but there's a place that people really want to go and it's across the park, and the walkway does not go directly there. People start walking there. And all of a sudden, once somebody starts doing it, they start making a path, and then more people start doing it. All of a sudden, you just have a path that is made. And it's not being made because you planned it out. It's being made because it was the thing that was happening. And so it caused things to shift around it. The same thing happens with chronic pain. When you are chronically sending pain signals, the part of your brain that receives them remodels. And so it makes it easier to receive pain signals because it's like, well, this is a thing that's obviously happening a lot. We should worry about this. Let's get into it. And so you will end up having major issues there. Now, the difference between that and between primary and secondary hyperalgesia is that you can have primary effects where basically you get inflammation and that causes sensitization. That's designed. You're designed to try to bring up and focus on attention there. And then the secondary one's what I was talking about. The difference between visceral and somatic that's really relevant here is in most chronic regional pain syndromes, you have an inciting specific injury. I got an ankle injury and now my ankle hurts forever. In visceral pain, that does not have to happen. It could start with the visceral pain being hypersensitized because there are weird countervailing reactions that can result in that and takes very little effort to develop a hyperalgesic response in terms of visceral pain. And so when you have this pain, like I was saying, this is really just interpretations of mechanoreceptors. So the best and most accurate sensors in your gut are stretch. That is the best thing they can tell. If you are getting that, you are able to tell what's going on. It's how you can feel things moving, but it can go haywire, right? Where individual movements can cause significant pain. And it also helps illustrate why we try to work so much functionally in these disease states and why, you might see me prescribe Miralax for almost everybody. It's not because the problem is that someone's constipated. The problem is that they have an issue which makes them wildly vulnerable to sequelae of constipation, which is a separate problem. So basically, you have something that's abnormal in your body's ability to sense signals from your mechanoreceptors. And accordingly, if you have something that makes you stretch out too much, that is really uncomfortable. So the problem with constipation is that it's leading you to have more distension, more gas, and more signal, which then means more pain. And if I get rid of that, I often can help minimize your pain. About 20% of kids in the United States will complain of chronic abdominal pain at some point in their childhood. 10% of these have a clear cause. Now, to be honest, if you're going to look at these, 80% are constipated. So, you're going to find a lot of them are, in fact, constipated, but a good amount of this is still looking at functional disorders or sensitivity to constipation was another way of reflecting that. Global pool prevalence is about 13.5%. There is a female predominance. There's an odds ratio of 1.5. When you have that small of an odds ratio, I often wonder about whether it's biological or sociological. However, there are some biological differences I'll get into in a little bit that do suggest that there is a predominance for women, specifically the constitutive activation of certain signaling factors that make you more vulnerable to pain, or more vulnerable to visceral pain. Higher prevalence in adolescents than adults. This has probably got something to do with essentially that the pressure to walk it off or deal with it is in fact partially therapeutic for some people. You will see improvements in functional attitudes if by someone who just is willing to tolerate the symptoms because they are not generally physically manifested, and so you can just kind of power through it and it doesn't cause a re-injury or secondary problem. And so there is a conditioning effect where essentially one of the main therapeutic modalities we use for this is something called acceptance and commitment therapy. Walking it off is one version of that. It's not the best adapted version of it. It's not the one that generates the best results for everybody, but it is a common one and one that generates a lot of impact and probably why a lot of adults who technically might meet the standard for functional abdominal disorders or diseases of gut-brain interaction don't complain about it because they're just like, well, I've got a touchy stomach. What are the risk factors? So hypermobility is a huge, huge risk factor. For people who don't know what hypermobility is, it's when you can do like this, and you should not be able to. Most common association with that is something called Ehlers-Danlos syndrome. There's a variety of different subtypes. But if you look at people with functional gastrointestinal disease, which was what it was called in 2013 when they did the study, 84% of people who are hypermobile had a functional gastrointestinal disease. And when you look at it the other way around, it's still an overwhelming amount of people with functional gastrointestinal disease also have hypermobility. And so there seems to be some association of this and postural episodic tachycardia syndrome. And what that really suggests, to be quite honest, is altered vagal tone. And I'll talk a little bit more about the vagus nerve in a little bit. Another thing that can be a major issue for these sorts of patients is if you have an underlying problem. So I mentioned that you could get hyperalgesic response without the inciting events. But if you do have the inciting events, you can also get them. So when you have IBD, when you have major abdominal diseases that cause, or GI diseases that cause pain, you very frequently have a comorbid functional gastrointestinal disorder or disease of gut-brain interaction. Risk factors, psychiatric, stress, anxiety, or depression. And it's really interesting, and there's some great work that's been done on this over the years by Sam Nurko's group at Boston Children's, is that if you see this early childhood adverse events, so birth trauma, abuse, severe injury, things that you do not remember, that you couldn't remember, will still increase your risk of this, suggesting again that there is a biological and biochemical underpinning to your sensitization to pain. So, one thing to remember about this is also that our gut is privileged as a response for triggering us to think about things or do stuff. So, we have on purpose a lot of sensitivity to the intestine. You are meant to have a conditioned response to that's poison. I'm not going to eat that. And people might have had that experience from eating certain types of food, getting sick and being like, well, I can't eat that again, or drinking too much of some specific alcohol and being like, never again. And where that smell of it makes you nauseated. And that is because it is very strong conditioning effect. You get that from your gut almost overwhelmingly. And it is really powerful. Additionally, there are also physical effects that can happen. Everyone's probably had the experience of really having to have to go poop. You really have to go poop. If it comes on strict quickly or you have gastroenteritis, you might get sweaty, heart rate changes. You might get pale because, again, vagal nerve signaling will alter your physiology and make you feel, not to have a pun, like shit when you have to go to the bathroom. That was to have a pun, that won't lie. So attention and pain are also really important. Pain tolerance is a trainable skill. There are people who can do things that hurt quite a bit and just do it over and over again, and it doesn't matter. People who are, say, boxers, long distance runners, Navy SEALs, all sorts of other stuff. And then some people get a paper cut, and it's all they can focus on. And I am in that second category. You really can mitigate your sensations of pain with perception. And this is not to say that everybody should walk pain off or that pain doesn't matter. That is untrue. It's just that some people have variable experiences of pain. And one of the ways in which we can modulate pain is to try to alter how we deal with that experience. So when you put pain into context, it can becomes a little bit easier to handle sometimes. But the other part of that is pain in context makes it a different experience. The example I would use for this is if you are playing soccer and you kick the ball and you score a goal, but you stub your toe, or you wake up in the middle of the night and you're going to the bathroom and you stub your toe. You use the exact same amount of force, the exact same amount of injury. Which one hurts more? Exactly. And it hurts more because you were surprised, because it was unexpected, and because there's no positive association. You scoring a goal, winning the game, you're happy. Pain is a very secondary process. People have had this experience where you do something great physically and you're like, that's amazing. And then you're like, oh my God, that hurts. Like about half an hour later, or maybe 10 minutes later, when you realize and the euphoria wears off, there is pain there. So there's a feedback loop here. Pain causes attention, attention causes more pain, which causes more attention. And the other thing about this that you can tend to think about as an analogy is you ever been on like a bus or a plane and you are listening to people talk and you can't stop because you're bored and there's nothing for you to focus on? So because you are stuck on a seat and people are having this obnoxious conversation behind you about, something weird or racist or unpleasant, and you're like, I really wish, or just boring or annoying, and you're just like, I wish I could not listen to this, but you can't. Attention really matters, and we need to recognize that because it means we have a fulcrum that we can move to try to improve people's experience of these diseases, even if we can't get at the underlying biological disorder. So now we're going to get into the mechanisms of it. And this is because I'm an epithelial biologist. I make everyone think about the mechanisms. I think that learning systems helps a lot to help people feel comfortable understanding why and what can happen and what is happening in various different medical contexts. So I like approaching it from the systematic approach, and we'll get there eventually. So the intestinal epithelium, it keeps out all the things we don't like. So bacteria, fungus, and virus. It's got antimicrobial cell functions. It constantly regenerates about every 7 days and has a robust epithelial structure, which is designed to be permissive, but also maintain specific orders for entry. So your goal for the intestinal epithelium is for things to come across it, right? You are meant as an entry point to your body. It is meant to absorb foods. It's also meant to allow antigens to come across to be presented to your immune system.
I just have a quick question, something that I was wondering. So, if it regenerates every 7 days, why does it take longer than that sometimes for, um, after people have gastroenteritis, they lose their brush border enzymes to some extent, and they can develop like a temporary lactose intolerance. It seems like that can last a couple weeks sometimes, right? But the whole epithelium is replaced every 7 days.
So the epithelium is replaced every 7 days unless you break it.
Oh, okay. So that
So,
slows
right,
down.
machines work better when they're functioning and no one's breaking them. It does still get replaced over about 2 weeks. However, a lot, as we talk about in the enteropathy lecture later, a lot of what cells do in the intestinal epithelium is decided by the cells around it, right?
Uh-huh.
Remember we talked about all those gradients and how that all works?
Right, right.
So what happens in the aftermath of gastroenteritis is that you've depleted all of the gradient signal because you've killed all of the apical cells. And so you've got all the brush border enzyme, the tip of the villus is all dead, all that signal is gone, and it takes the redevelopment of the enterocyte signal and a couple other ones to actually create the microenvironment to cause differentiation to occur again, which can take quite some time. In the
I see.
meantime, you've got dysbiosis and you've got secondary damage in the form of usually lower PO intake, and your PO intake is a major trophic stimulant. Beyond that, there's some evidence that viral infections may deplete local serotonergic microenvironments, which causes you to essentially drop one of the main proliferative signals.
I see.
So
Okay,
you're
that makes sense.
the short answer is that's how it works if you don't break it. The long answer is it's variable because there's a multifactorial answer about how it regenerates.
Gotcha. Thank you.
Does that make sense?
Yeah, yeah. No, that makes
Yeah.
sense. Thank you.
Cool. Sorry, I get too into things and I answer very esoterically sometimes. So you do want to have your barrier be intact. You want it to function because your goal is to keep good things in, let good things in and keep bad things out. So it's really more of an entry point or like a customs area. The problem with that is that much like that, because it needs to be dynamic, it doesn't maintain a tight wall. It maintains like a wall that's more like a bunch of people holding hands and doing a hands across America, which means if someone needs to come through, you can let your hands go and then you can let them back, let them go, let them come back. But the problem is sometimes this happens too much. And if you get the wrong things through, they cause trouble back there. Imagine letting a bunch of stuff through that then starts running into you from behind or causing issues or calling bulldozers to come hit you or police cars to shoot you. These are all problems. And so this is what happens when you let bacterial peptides in or overwhelming or actually full on bacterial translocation. So you need to have an intact epithelium or you start to have issues. When you get stressed, this messes with the epithelium. Chronic stress will increase endogenous glucocorticoid. Endogenous glucocorticoid, much like it does in some other places, is strongly anti-proliferative and can damage barrier function. So you will end up with major issues in terms of being able to regenerate your barrier and create some enteropathy and barrier defects. Sympathetic nervous tone, or what you generate when you're stressed, also messes with the intestine. It blocks intestinal stem cell proliferation with alpha 2A adrenaline receptors and M1, M3 acetylcholine receptors. This comes up later because one of the things you might know if you do other kind of pain medicine is that chronic regional pain syndrome loves SNRIs. But SNRIs and TCAs both activate alpha 2 adrenal receptors. And they don't work as well as SSRIs do in DGBI for that reason, probably. We don't know entirely, but that's my theory. Sympathetic tone can also impair intestinal motility and decrease intestinal secretion. When you get norepi triggers, it does release NPY and somatostatin. These both are also anti-proliferative and anti-movement, which results in abnormal movements, which makes what happen? If your problem is over distension and then you change the movement pattern of the intestine, what's going to happen?
Pain as it tries to contract on it's already over full.
You're going to get basically uneven distension, which is what triggers the worst kind of pain. So it leads to pockets collecting because instead of being a smooth peristalsing hose, it turns into somebody essentially manually squeezing a bulge through. And that happens irregular and randomly. So you get episodic movements, episodic changes. You don't get used to them. You cannot sensitize to them. They happen randomly and they happen in different places. So it results in you getting pain. Here's a nice cartoon to break up all the biochemical stuff I'm saying. My general rule for all the fellows is that if you're writing a talk and it has a lot of science in it, you need to put silly things in periodically or everyone's brain melts. So the enteric nervous system, over 100 million neurons integrated with intestinal epithelium and immune compartment, and it regenerates. This is actually really interesting. We used to think it didn't regenerate, but it in fact does. And it is in fact preferentially injured, as I'll talk about in a little bit, in certain kinds of inflammatory states. It is independent of the central nervous system, but can be influenced by it. So this is where the vagal nerve can influence the ENS, and it directly connects to enterochromaffin cells. This was actually discovered by a mentor of mine at UCSF. He is a very smart man named Jim Breyer, who's also discovered some other stuff that's really cool about these conditions. Um, and it is, I'll talk about a little bit later, the pictures of it, but enteroendocrine cells are the paracrine endocrine cells of the gut. These are the ones actually in charge of your intestine. They do a whole bunch of interesting and cool stuff that you need for a lot of different things. So they regulate motility, barrier function, proliferation, regeneration, immune response, blood glucose regulation, satiety, pancreatic secretion, growth. There is an important thing to know, which is that the intestine rules everything around it. It is the most important organ in the body, in my opinion, and also, I believe, supported by evidentiary basis. So when you have the ENS, it can signal change. It will alter enteroendocrine cell function. This is pretty relevant because of enterochromaffin cells in particular. These are the largest source of serotonin in your body, about 80% of the serotonin. And it is a major issue because serotonin is really important to intestinal function, but it depends on where it's coming from. EC cell serotonin is pro-inflammatory and can alter movement in weird ways, as ENS serotonin is pro-regenerative and proliferative, so it makes the intestinal epithelium repair itself and tends to support normal movement. So it matters where you're sending it and where you're putting it. Here's a nice picture of that synapse. Basically, what happens is that the ENS nerves have synapses that go to the EC cells, and they follow the EC cells up the villus as they extend out. Basically, the way intestinal epithelial works is that there's a crypt at the bottom and it moves up an escalator. So you make cells, they start to differentiate, and they further differentiate as they move up until they get to the top, but it's the same cell from the bottom. So when you have an EC cell start to form, the basically the synapse meets it and then travels up with it until it extrudes or dies, and then it forms a new one. So there is a persistent neuronal connection to your gut. And this is really handy because it gives us a whole bunch of information, a whole bunch more clarity about where we think some of these defects are occurring. So this is a little bit of just discussing the mechanisms of how stretch can actually cause some of these issues. So you get luminal distension and distortion. This triggers activation of the intrinsic primary afferent neurons, or IPANs. These are also activated by release of 5-HT from enterochromaffin cells. This is part of how you sensitize your pain nerves in response to inflammation. Your enterochromaffin cells are meant to respond to bad things in your intestine, so infectious agents, other stuff like that. And when you have them come across, you are meant to signal this serotonin release to say, hey, we got a problem. So it speeds up movement through the gut and creates diarrhea in some cases, but also triggers pain response and local sensitization because it's saying you ate something dangerous. Don't eat that again, or maybe consider vomiting. Like that's the sort of stuff it wants you to do. Post-viral changes are really interesting in this, and this hasn't been fully but there are enough. This hasn't been fully recapitulated by other people, but there has been enough evidence suggesting that when you have an infection, certain aspects of the ENS are preferentially damaged, and in particular, the VGLUT2 neuron after infection. When you lose these are the promotility excitatory cells. So these are the ones that trigger the intestines to squeeze. Losing them would create what kind of problem, Bryce?
Um, if you
These are excitatory motility cells. If we kill them, what happens to the gut?
you wouldn't have peristalsis, so it
Yeah,
would
it does not move well.
tend to be sort of like having Hirschsprungs everywhere, maybe.
Sort of. This, it doesn't get that severe, but it does get quite annoying, very frustrating, and leads to that same sort of irregular movement effect I was talking about before, and can trigger the functional disorder that occurs afterwards. This is probably happening because of muscularis macrophages. Muscularis macrophages are kind of like glial cells, but for the ENS. They are the immune cells that are there to be body men for the neurons. So they exert protective regulatory effects for the ENS cells. They live in the myenteric region. And if you deplete them, you end up losing more of the ENS cells in an infection. So you want to sustain the muscularis macrophages cells because they protect your vulnerable enteric nervous system cells and during an infection, which can suggest a couple other targets. Excuse me. One possible emerging target for this is use of beta agonists. So beta agonists actually do seem to protect and reinforce appropriate function from the muscularis macrophages, which results in protection of the neurons when exposed to S-typhimurium. So this is a really interesting process because there are a lot of very safe long-acting beta agonists we could consider studying for this, and there are a few people who are looking into this in terms of studies to see if there is any effect of it. It's also possible that this may not have any benefit to someone who's actually got a disease, but would only be useful prophylactically, in which case that's extremely hard to deploy. So it may or may not be useful, but one thing we could look at is essentially whether or not formation, actually this is an interesting research idea, whether formation of these diseases is lower in people who take them habitually, because long actings are much more commonly used now. So we could look at that in the asthmatic space. In fact, I might look at that in Trinetics when we're done with this talk. So another break. Peripheral serotonin, over 80% of it is in your gut, mostly in the enterochromaffin cells. It mediates GI pain, nausea, and motility. Where serotonin comes from is really important, as I mentioned. If you have it from the EC cells, it's inflammatory and pro-movement. If you have it from the ENS, it is pro-regular movement and pro-proliferative. So you like that. It's very helpful. Studies of serum serotonin correlation with symptoms have been challenging. And this is really challenging primarily because serotonin, like zinc, is one of those really hard labs to get right, partially because serotonin binds to platelets. So if you look at this in serum, it can often be inaccurate or very incorrectly measured, and then people just measure this inappropriately. So there are some suggestions that we do see serotonin drops with these things. However, it's really not easy to say. And it's also not clear that all those mechanistically were done correctly. 5-HT2 and 3 receptor activation directly increases pain sensitivity. This might also suggest a drug that could be helpful, or why some drugs that we commonly use are helpful. Is there any drug you can think of that uses 5-HT3 receptors?
SSRIs?
Well, that would have a partial effect. That's serotonin broadly, right? But what about, is there another drug you can think of involving 5-HT3 that we use in GI? Yes, Zofran. Yeah. Now, is there any evidence that Zofran helps with abdominal pain? There is, in fact, evidence that Zofran helps with abdominal pain. Another medication like Periactin is another one that we use that could be related to this. So and Remeron, other stuff like that, we'll talk about those a little later. But this does actually help. And so these are the signals, and this is why we see some benefit to this in patients. So the vagus nerve is the really important nerve. This basically is a nerve when you're sitting on the beach or having a great day and something great just happened and you feel glowy and awesome. This nerve is working overtime. This is the nerve that modulates that feeling. It also modulates when you feel like things are awful. If you're having a panic attack or you're really sick, it's really not fun. And it can control both those things. The tone is analgesic. So when you have it going, you feel less pain. This is in part of why when you kicked the soccer ball and scored your goal, you were not in as much pain because you literally were not in as much pain. So even though the same event triggered the same damage, it doesn't trigger the same physiologic effect in the body. 80-90% of the afferent signal in the vagus is from the intestinal wall, and 20% of the vagal efferent is to the gut. So this is very heavily linked to the gut. It is really, really tied to it. Decreases heart rate, vasodilates, improves motility, and decreases inflammation. Now, these are sort of the inverse of what happens when you really have to poop. So these are related signals. Your intestine can modulate vagal tone. The vagal tone can modulate intestinal function. Vagal tone is a compensatory response to stress. If you have a high baseline vagal tone, you generally tolerate pain better. This is particularly strong in visceral pain. When you look at this, you get to expose also one of the more interesting things, which is that humans are one of the only animals that gets to experience pain 3 times. And this isn't the only one, other animals can too, but we are particularly smart and particularly prone to this kind of introspective process. But if you look at fMRI, the experience of being hurt, of remembering the pain, or of worrying it's going to happen again are remarkably similar in your brain. So you end up basically having the same sensation or even the same feeling or the same distress, at least the same ways, even if you're not actually being injured. So again, our conditioned responses are really important here. When you look at emotional state and perceived pain, you also see things. If you are in a bad place and something happens, like imagine you're already frustrated and then you stub your toe again. That's even worse than the middle of the night. It's like, oh God, this is the worst. When you look at this, it's very, very clear. Anxiety and depression exacerbate pain. This is the reason why we see that linkage with diseases of gut-brain interaction, which is that one, if you have a DGBI, you have a chronic noxious stimuli that's going to make you probably have an unpleasant time and create anxiety and depression. 2, once you get those anxiety and depressions, it makes it worse. So the patients we see often do have comorbid anxiety and depression. is not because this is a disease of mental health, but because mental health can exacerbate problems of pain and distress. And this is a common thing across all sorts of stuff. People with cancer do better if they're not depressed. People with lupus do better if they're not depressed. It is a common factor. And so we need to be aware of that and factor that into how we approach treatment and our patients. One interesting thing that is really fun to note is the actual physical remodeling of the brain that occurs in these diseases. So this one isn't actually from DGBI, this is from chronic hip pain. And the reason why we use chronic hip pain for this study is because the study has one specific thing that can actually fix chronic hip pain, which is a hip replacement. So hip replacements are remarkably good, like really, really good. People get a lot better function once you get the hip replacement. However, not however. So then you can look at that and use that as an inciting point and say, okay, people who had chronic pain before, now they have no chronic pain. What changes? So this is an fMRI study or an MRI study looking at these things that was able to identify that if you see somebody who's got chronic hip pain, it results in gray matter changes and decreasing that gray matter in the area that receives that pain. When you fix it, it gets back to normal. So you can actually see changes and functional shifts driving just from this. This is a little bit more unclear. I mean, there's more data on this than in the studies I put in here. These are a little bit older, but again, it's still not very clear. The microbiome in DGBI is altered. We do know there are shifts. We do not know whether or not those shifts are that. We don't know how to drive those shifts in meaningful ways very well. So we know that VSL3 has some protective effects. Prebiotics have demonstrated some effects. The difference between prebiotics and probiotics is basically prebiotics alter the microenvironment but don't have bacteria. Probiotics are actual bacteria. The difference is, and why prebiotics I think work much better, is imagine you took 50,000 Amish people and put them in Times Square. They're not going to be thrilled just because you put them there. But if you make the environment of Times Square look a lot like Lancaster, Pennsylvania, they will be like, cool, this is fine. So you need to make the environment the way the bacteria would like, and then they will end up there, as opposed to if you put bacteria into an environment they hate, they will leave or die. Combination can be good. People have done a lot of combo, what they call and symbiotics is the sort of the combination approach. If you're going to pick one, I pick prebiotics or probiotics. Sorry, prebiotics. And but the problem is still with probiotics is we still don't know exactly which ones are ideal. And the nice part about prebiotics is we're just creating a circumstance that is ideal, and then the right ones come, we think, but function works. As opposed to probiotics where maybe you do want to have lactobacillus, but maybe you don't want to have the wrong proportion of lactobacillus, and maybe now I've given you too much lactobacillus, or maybe I've reduced other proportions. It's difficult. Thing is, we just don't know. It's true. We can tell that there's an important thing there, and not necessarily how to do it, if that makes sense. So to kind of recap, intestinal barrier function protects against local inflammation and nociceptor activation. Microbial populations can affect barrier function and pain sensitivity. Stress alters ENS signaling and releases glucocorticoids and adrenergic signaling, disrupting the barrier. Infections alter ENS function, disrupting both motility barrier function and leading to worsened triggers of hyperalgesia. And stress increases pain sensitivity centrally. Vagus nerve signaling counteracts these effects, but low tone increases risk of aberrant pain signaling and is linked with mental health disorders. So let's talk about therapeutics. So the reason why I went through all that mechanism, all that background, is so we can tell why therapeutics are good or bad. Opioids are forever bad in these diseases. Do not use opioids in these diseases. They make it worse. They make it worse for a variety of reasons. One, constipation. Main side effect of opioids is it messes with movement of your intestine. We just went through a whole lecture talking about how altered movement of the intestine alters distension patterns and worsens this pain. So basically, opioids make things worse functionally and only cause relief if they get you high. And to be quite honest, there are other things that get people high that are not nearly so negative for the intestine, and I would rather they were be on those things because this is particularly bad. Additionally, it suppresses vagal tone and drives hyperalgesia. When you take opioids, the hyperalgesic effect can last up to 6 months, and that's from one pill. It stacks when you take it frequently. So you can get long-lasting, sometimes semi-permanent hyperalgesic response because you've taken exogenous opioids, and you just can't really ever fix that. This is part of how tolerance works to some extent as well, because these are products and signaling factors that you make endogenously in your body. And when you upregulate them like that, it's the same thing how you can't take somebody off of glucocorticoids cold turkey, you create problems. Neuromodulators is the better term, in my opinion, for antidepressants, which is to say drugs that are there to alter how your nerves are functioning. And so these are the classic one that we use in DGBI is amitriptyline, which is a tricyclic antidepressant. This inhibits serotonin reuptake, noradrenaline uptake, and anticholinergic effect. It has an anticholinergic effect. All three of these, two of these are probably positive in the gut. One of them is probably negative. The noradrenaline is not necessarily very helpful. And when you increase the norepi signals, it is great for neuropathic pain and somatic pain. It is not really ideal for the intestinal barrier. So we generally would probably not want to use that. So I don't recommend use of SNRIs, although I do love a lot of other drugs, which I will talk about in a second. This is one of my favorite drugs in existence, mirtazapine, aka Remeron. It is a 5-HT3 and alpha 2 signal antagonist. You can probably tell from my lecture why that might be helpful in this context, because you are blocking stress-induced barrier dysfunction, and you are blocking the 5-HT3 induced nociception and barrier effect. So you are essentially interrupting the enterochromaffin cell's ability to mess with all of its friends around it. This is really, really great, and also has a couple other nice side effects for a DGBI. There is a heavy association for DGBI and altered sleep patterns. We see this in part because of probably the anxiety, but it also probably leads to altered vagal tone and dramatically increased sensitivity to pain. If I fix your sleep with something that makes you sleepy, you do better. Same thing if I am able to fix your appetite. A lot of this maybe comes from altered sensitivity response to foods and other things like that. If I make you hungry and you eat better, you're going to have more normal relationship with food and address some of the other issues. My favorite part about it is that it's got one of the most absurd safety profiles known to man. You can take insane amounts of this drug and nothing happens. And there's no discontinuation syndrome. The most that happens is you get sleepy and you fall asleep. You really are not going to create any risk of this. So this is a very safe drug to use. And a lot of people get antsy about using these drugs because they don't want to be doing psychiatric care if they're not psychiatrists. And I would say that is fine. And if you have a strong worry for major depressive disorder, that's very appropriate. You can still have issues like activation, which is when you start someone on antidepressant and they get enough energy to hurt themselves before they have actually fixed the depression. But we're not treating the depression. These are all dosed and aimed at treating pain. So I use these all the time and I have them work really, really well for me. And the main thing people don't like about Remeron is sometimes they feel a little too sleepy. So then I also use SSRIs a lot. And these are great. These are known to increase vagal tone, which is really, really wonderful. SNRIs are not known to increase vagal tone, likely because of the noradrenergic effect. What I have found works really well with SSRIs, the thing people have had trouble with them is that when you start them at a full dose, sometimes people get worsening of GI symptoms. One of the main side effects people get from SSRIs when they start them is gastrointestinal side effects. If you start them at a 1/10 dose and titrate up with a liquid, I have never had anyone fail. I have heard from people in other practices that they fail all the time when they start SSRIs, just because they start them on 25 or 50. And so I start people on use 20 milligram per ml liquids, so 0.1 ml. So you squirt a drop into your mouth, but it actually works, and you titrate people up, and you see really good results. So when you compare this to TCA, you see a much stronger improvement, about a 14% improvement. And again, you're probably looking at a lot of this is even bigger than that because probably half of that effect was placebo in the first place. So the percentage difference is likely much stronger for SSRI over TCAs. So again, we're looking at really nice benefits for SSRIs, and this is why SSRI and Remeron are my two favorites. And you guys never really see me write for amitriptyline or other kind of similar medications. Ketamine is one that I'm interested in. I think there's been a lot of work. It was very popular when I wrote this lecture a few years back. It's kind of decreasing in popularity now, likely because it's been hijacked by people who do sort of illicit fake ketamine therapy. Ketamine assisted therapy is extremely effective as long as you're actually getting therapy with it. Just taking ketamine is not going to fix your depression for any longer than the time that you are on the ketamine. However, it is an interesting pain medication because it has a sort of altered relationship with pain as opposed to controlling pain. So it basically just changes your perception of pain, which might actually be really useful in these disorders. There's been studies of people looking at essentially periodic infusions of ketamine to see if this causes some long-term benefit to chronic pain. And the chronic pain studies ambiguous because they're all kind of messy, sadly, but they do suggest a benefit. But there's very little study of this in functional gastrointestinal disease. I will note that there are a couple of groups that have seen some benefits in this in terms of managing chronic pain disorders in people with known chronic disorders, such as, for example, recurrent pancreatitis. So UCSF, I talked people into doing this where we were looking at essentially for people who came in with recurrent pancreatitis or had an ERCP, we would do ketamine and see if that altered the opioid use. And we were able to show in the same way we can show this post-surgically in a bunch of other places in medicine that it does alter the opioid use. It decreases it. So ketamine is often an opioid sparing thing for things with chronic disease. So you might think of this has some potential for other possible aspects. We probably can't really study this in kids because it's difficult to get an IRB to let me give kids a bunch of ketamine for funsies. However, once it's studied in adults, I'm hoping that we'll be able to take that benefit down to children and find ideal doses that are not as dissociative or hallucinogenic, but are able to provide the same sort of benefit to resetting pain sensitivity and the vagal tone. So here's another analogy. You guys remember that fire alarm analogy? And this is another one that I like to use about treating this condition. So this is the finger trap analogy. And the main thing that you want to remember here is this algorithm that was taught to me by one of my mentors in fellowship, Walt Sipe, who did a full PEDS GI fellowship after a PEDS residency and then decided he was going to do a psych residency and then did a sex med psych fellowship after that. So now he does a combination of chronic pain and sex therapy, which is honestly like he's just making sure everyone's life goes great. You can eat and you can do whatever you want to do at other times. But his analogy here, and his statement here is suffering is pain times attention. And I think that is a really useful frame because pain is irrelevant unless you're paying attention to it or you care. So lots of people will come in with awful pain or things where you're like, how are you tolerating that? And they're like, I don't care. And it matters only if you're missing something that's creating additional damage. In these diseases, there's no additional damage. The damage that's done is done from how you acclimate or acculturate to your disorder. In this case, this also really helps you think about it because if you know that the pain is an aberrant signal and the problem is that your body is generating pain signals when it shouldn't, and the more you focus on it, the worse the pain gets. Trying to fight it is a trap. So the finger trap analogy is basically the idea that when your fingers are in a finger trap, the way you get out is pushing in and having one out. So you have to be controlled on top of it and keep your calm. And the same thing happens here. If you freak out and you say, my stomach hurts, and every day your parents ask you, does your stomach hurt? Does your stomach hurt? How's your stomach today? What's going on? You're thinking about your stomach all the time. And I can do this to people with a conditioned response with something where I have you go through and focus on the tip of your finger. And if I do an exercise where you focus on the tip of the finger and I train you to think about, feel the warmth of the tip of your finger over and over and over again, and then I do it over and over time, this gets faster for you to the point where now when I do it, I already start to feel tingling in my finger just from mentioning it because I've done it so many times that you can generate that same sensitized response. And it's the same thing that happens with pain disorders. If you focus on it, it gets worse. And that is really an annoying thing to tell somebody because they have pain and you're saying, ignore it. But that's not what you're saying. You're saying, okay, we know that you have pain. We know what's going on. We're taking these steps to alleviate it. At the same time, there will be some. And part of what we need to do is learn how we tolerate that and learn how to function with that because, and this is a thing I stress to patients all the time, nobody feels good every day. Nobody in the world feels good every day, except for maybe some kids. And so for the most part, this is just life. And sometimes your body hurts and it doesn't work great. And it's about figuring out what the difference is between signals you need to pay attention to and signals that you can be like, okay. So this leads to the non-pharmacologic approaches. Biofeedback is really effective. It is extremely hard to find anyone to give it to our patients, and in particular, our patients here at Downstate. We definitely cannot find anyone because it's almost never covered by insurance and costs a lot of money. But it is quite effective. And this is basically vagal tone training. You are more or less teaching your vagus nerve to function more appropriately. Acupuncture and acupressure works along the same lines. It increases vagal tone. This is entirely based off of you believing it's working. And that's fine. This is the biggest thing about it. Any intervention that a patient wants to try that isn't toxic and doesn't bankrupt them or cause harm in some way is fine. If it makes you feel better, it's going to make you feel better. And you don't need to be looking for the biochemical effects. Some of these things are driven by biochemistry and are things that have interesting effects on strengthening barrier function or smoothing out motility or changing pain perception. But most of this is just stuff that, like, maybe, I don't know, maybe it does something, who knows? But I don't care. I'm not going to sit there arguing with acupuncture, acupressure if my patient feels better, because my patient's problem is their pain. And if their pain is better, okay, it worked. So these things work if you believe they work, and engaging with it really helps. So yoga works, meditation works, all these other things work because they alter and improve vagus tone. Physical activity works if you can tolerate it. If you can't, it does the opposite. So you just end up resulting in it. So you want to focus on a not a one size fits all approach, but one catered to your patient, because there are a variety of different things that will help with that. CBT is quite effective in functional gastrointestinal disease. What I find really interesting in pediatrics is that CBT of parents is equally as effective. And this probably speaks to the underlying part of this, which is that it's your perception of it that matters. And kids get a lot of their perception from their parents. So if your parents are like, it's really not a big deal, you're going to be like, it's not a big deal. If your parents are like freaking out every morning that you're in pain, you're going to freak out every morning that you're in pain. So you can create generative effects by giving therapy to parents, which is fascinating. CBT is a solution not because it solves the underlying problem. It does not. It's a solution because it solves how you acclimate and deal with the problem, resulting in you feeling better. So it's not a real solution. It is a band-aid. It's symptomatic therapy. And one of the big debates right now in the field of uh, functional gastroenterology, neurogastroenterology, depending how you want to call it, is sort of how do we keep going down some of the psychogastroenterology parts where we are essentially treating symptoms, or do we go down more of the mechanistic parts? And I'm more of the mechanistic kind of side. And I think we need to get to the bottom of it, because we've got a lot of things packaged around treating the secondary effects, but not around actually addressing the underlying problem or understanding it. There are some barrier microbiome approaches. Iberogast is an herbal combination that you can buy on Amazon. It appears to enhance barrier function. It's been studied a couple times and beats placebo. VSL3 Herbis Biome now, not really well shown for this in human trials for IBS, but has been shown in IBD. Prebiotics, there is more data. Again, it's really messy. The problem with these studies is everyone does really small ones with very variable exposure conditions. So it's really hard to kind of say if anything's there. Linaclotide is a laxative, does decrease nociception, probably be an enhancement of intestinal barrier function, upregulating cyclic GMP. There are some new drugs like tenapanor that work similarly. Tenapanor is a NH3 inhibitor that will also cause barrier improvements and increase secretion, decreasing constipation. And here's the intestine disagreeing with all sorts of foods. So this is an interesting one. This one works really, really well. The low FODMAP diet. In theory, it's decreasing GI stretch. Basically, this is about equally as effective in studies as any therapy in DGBI, if not actually more effective. It works extraordinarily well in patients who have hypermobility, so like wildly out of control well. It is basically, these are fermentable oligodimonosaccharide and polyols. These are fiber. This is the fiber that you eat. Your intestines, the bacteria ferment it. They ferment it into acid, and they ferment it into short-chain fatty acids for the most part. You need those short-chain fatty acids, so not fermenting it is a problem. But also, they can create secondary issues like gas. And this can worsen IBS, and the acid can worsen IBS. There's a whole bunch of secondary things we know are associated to this that are not ideal. And so if you get rid of FODMAPs, you generally get rid of gas. If you get rid of gas, you generally get rid of pain. So low FODMAP diet is quite effective. And the problem is using it long-term is associated with developing artificial restricted feeding disorders. And then you really do need to have fiber going into your body for your colon in particular. Can any of my fellows tell me why we need fiber in the colon? Not just for laxative purposes?
Enterocytes eat the short chain fatty acids
How much of
because
their
they
energy
fully
comes from
embed
short
them
chain
from.
fatty acids fermented from fiber?
I think like 50 or 60%, but I'm not sure.
80%. 80% of the colonocyte energy comes from this fermenting. So if you kill this indefinitely, you will actually create a colitis. It's hard to do, but it's been done. Antibiotics are a common approach. These are not an approach I use. I don't really think they are a great idea. I understand why they work. I just don't think that they are going to create long-term benefit. So basically, rifaximin and flagyl work in IBS. They work the same way the FODMAP diet works. They kill the gas. If you kill the bacteria, nothing's there to make gas. But what happens after about a few weeks? They come back. And it's often not the right bacteria. Each time you take antibiotics, you increase the risk of developing IBD, you increase the risk of developing other stuff like that. You have secondary problems. You might create dysbiosis or other secondary concerns. I'm not convinced we understand enough about the externalities to make this a valuable approach. And there are other ways to control for gas from dietary intake. So I usually would use that. So you pretty much never see me use these antibiotics, although a lot of people find them to be very helpful and patients find them helpful. I use these solely in shortcut because in shortcut, there's no real other way around it. And this is a really major problem. And also in shortcut, you're trying to do things like deal with D-lactic acidosis or other major diseases associated with that. But broadly, I almost never use these sorts of antibiotics unless somebody's had an ileocystectomy and like there's a reason to go after it, that I'm going after colonic bacteria that have migrated up to the small intestine. Antispasmodics, I also don't use these a lot, mainly just because they're really hard to take in the time horizon that makes them work. So Bentyl and Lepsin are selective anticholinergics that block smooth muscle contraction. So this blocks essentially spastic contraction, which helps improve the feeling of distension in your intestine. However, you have to take it when it hurts, and often the pain lasts like 10 to 30 minutes. So like this is really hard to functionally take. And I don't usually recommend taking it every day because it causes constipation, which worsens the underlying disease. So you've got some issues there. Some people will say, well, people have had a good positive response to peppermint oil. You see good results from peppermint oil. I think it's great. I recommend people take it all the time. I have no major concerns about it and frequently use it. It's just sometimes people don't like it because it gives you peppermint burps, which is real and apparently discomforting, although it seems to me would be nice, but I guess maybe I'd get over that after a minute. Here are some IBS-D therapies that are interesting. So these IBS-D honestly it should be really considered a totally different disease than IBS. There is clearly much more biochemical causal linkages, and it's a very specific set of phenotypes with the diarrhea. But you can see some improvements with 5-HT3 antagonist, elocitron, which impacts serotonergically mediated movement and secretion, which decreases diarrhea. And then aleuxidolene, which is a mu and kappa opioid receptor agonist, which is an delta receptor antagonist. This blocks opioid-mediated secretion, motility, and some discomfort, but the delta agonism limits the constipation. So you basically get a slowdown, but not an ileus. It works quite well. When I've had two patients with IBS-D, I had both of them on aleuxidolene. I've never used elocitron. It's very difficult to get started. It's only available for women and has a bunch of safety issues.
Hello? I think I've lost your audio.
Can you hear me, Bryce? No? Anybody hear me?
Yes.
Okay. Bryce, can you hear me now?
Yeah, it's back now.
Okay. So this cartoon is not actually a brain break. This cartoon is an actual summary of what I do frequently for these patients, which is acceptance and commitment therapy. So I am a trained acceptance and commitment therapist. This makes me probably pretty annoying all the time, where I'm like, oh, that's a problem. How are we going to deal with it? And like, blah, blah, blah. And you guys are like, can we just fix something? And I refuse. So, with this suggestion, a taco, that's one. And then multiple tacos, that it doesn't matter. It doesn't matter what your patient says. If they're doing better, they're doing better. It doesn't matter what they're doing. If it's not toxic or dangerous or ruinously expensive, that's okay. It doesn't matter, any number of things, how they go about it. You were just seeking incremental benefit and improvement. Your goal is to divert attention while we try to control some of the baseline signaling. So I approach these things in two different ways. I will try to decrease initially, to try to keep people off medications. I essentially try to put them on laxatives to get all the signal out of your body, and at the same time reinforce that you are safe and okay, so that you can hopefully deprioritize that pain signal. We also really think that everybody should get physical therapy if they are disabled. If they are not disabled, one thing that really throws parents is that I frequently will say, even if they're not going to school, you should let them socialize. And this throws people because they're like, well, if you're not well enough for school, you're not well enough to do things. Well, those are unrelated and different things. When you don't feel good, it is much harder to mobilize yourself for school, and that can make it feel worse. But if you're doing something pleasant, you get vagal tone. And your goal here is to return vagal tone. So I really do push to focus on functional goals. I say, okay, they had to miss school. You should tell them to go see the movie with their friends. You should tell them to go play with their friends. Oh, they're playing video games all night. Well, don't let them have disordered sleep, but you don't need to banish video games. You just say, okay, these are in the right context and the right time. And the fact that they're playing the video game doesn't mean that they don't have pain. It means that it's a nice therapy for the brain because they're distracting themselves from focusing on it by giving them something else to think about. It's like being on the plane. Instead of having to listen to somebody, now you've got a good book to read and you just don't have to hear that story anymore. They're not doing it to be jerks. Now, every so often, somebody's got secondary gain or is manipulative. That's a different story. But most of these kids are not that way. Most of these kids are type A kids who would rather be at school and are just kind of losing it and can't handle it. Direct vagal nerve modulation can be quite effective. SSRIs, mirtazapine, biofeedback, CBT, auricular stuff. This all just works on vagal tone. And so we can actually just put a device on that makes the vagus go and turn on. So these devices work really, really well. They work really, really well at a myriad of indications. They are one of the most impressive inventions that we've had recently. They're covered by an IND from the FDA, but they are not covered by insurance. And so I have not been able to use them here, but I used them at UCSF before I came here, and they were extraordinarily effective. The data on them is quite overwhelming. Basically, it's a earpiece with 3 minor electrodes that pierce the skin, and you change it once a week. It does not hurt to put on, and it's like overwhelmingly powerful. So TENS units can also be somewhat effective, but not nearly so much. It's generally probably because it likely has to be applied at very specific places and people apply them sort of nondescriptly. Our number one therapy and our best sign of success is that our patient is back at school. This is my strong threshold. I don't expect 100% resolution. You do achieve it sometimes. It's really more based on the kid and the environment. Basically, people in a really great environment can achieve 100% resolution in DGBI. Otherwise, probably not, because you're going to have a bad day. You're going to have a stressful day. Your parents are yelling at each other. Your parents are yelling at you. You got a bad grade in school. There's a flood. There's the subway's flooded. Who knows? That can trigger you and knock you off. So having some pain and some disorder is not, I think, a sign of someone who's being poorly managed. And it's really key to keep that stress to your patients so that they know, hey, it's okay if I'm having a bad day or a bad time. It's okay if this is happening periodically. I still know what's going on. I still understand what's happening in my body, and I will deal with it. And that really helps you tolerate this better, which creates a better circumstance for it to not happen again, which is super weird and very annoying and feels very fluffy to people sometimes. It feels very much like I'm talking hippy dippy stuff to parent. And in San Francisco, they loved it. And here, they're sometimes a little stupid, skeptical. But it is, it's definitely just how it works. Your mindset does alter your perception of pain. And it creates this interesting space where I think people get judgy about DGBI because some of the most efficacious treatments happen to be rooted in mental health, even though it's not a mental health disease. And I think that's why I like to really go through the mechanisms here and really talk about the basis of it so that people understand this and can put into context what we're doing when we take care of these patients. They have the same biological disease as everyone else. This is not the right version of the talk, so I did not go through some of the new findings that illustrate that and highlight that specifically in women. But there is a lot of emerging evidence of underlying biochemistry driving these conditions. It is quite clear that these are physiologic disorders that are interacted with by mental health disorders. And I hope that I presented the evidence today that lets you guys feel comfortable in making those distinctions. And for those of us in pediatrics or GI, in feeling comfortable prescribing SSRIs and Remeron, because they really are safe drugs to use and they are quite effective in these disorders. And that's that.